Yes, thank you so much for your introduction, Lawrence. And thank you so much for giving me this great opportunity to talk in this uh, uh, important symposium. I'm sorry I can't be with you in person, but I will do my best online. So let me share my slide. I hope you can see my slide, okay? So I have been working both in Japan and in San Francisco at Gladstone Institute. In Japan, I have been working with many other scientists to bring stem cells to patients, translational research, whereas in San Francisco at Gladstone Institute, I have been doing my own basic science on stem cells. So in my today's talk, I will focus on our translational activity, mainly in Japan. So this is the stem cell we have been working on for the last 15 years, iPS cells, induced pluripotent stem cells. So we can make iPS cells from our own skin or blood cells by transplanting, by introducing, I'm sorry, we have the pointer, by introducing the combination of these 4 transcription factors all together into skin or blood cells. These factors can change the fate of somatic cells back into the embryonic state. So the resulting cells are nearly indistinguishable from embryonic stem cells, ES cells. The only one difference is the origin. We don't have to use human embryos in making iPS cells. So we published mouse iPS cells in 2006 and human iPS cells in 2007. So it's been 15 years. After publishing human iPS cells, our university, Kyoto University, has decided to launch a new institute exclusively for iPS cell research and application. It's Center for iPS cell research and application, CIDA. We have a common mission, which is to bring iPS cells to patients. There are 2 major medical applications of iPS cell technology, which is shown here. The first one is regenerative medicine. The second one is drug development. Once again, we can convert patients' skin cells or blood cells. Nowadays, we mostly use peripheral blood cells, but by the simple method I just described, we can convert blood cells into iPS cells. Once they become iPS cells, we can expand as much as we want. Then, after expansion, we can differentiate iPS cells into many types of cells, such as brain neurons, heart cells, muscle cells, hepatic cells, and so on. By transplanting these cells back into patients, we hope we can induce a recovery of the function in patients, which is called regenerative medicine. Also, we can use these cells in vitro in pharmaceutical companies or in universities to search for novel drugs for many intractable diseases. So let me first, in this talk today, let me focus on the first application, which is regenerative medicine. So once again, we generated human iPS cells. We reported human iPS cells in 2007. And at that time, I thought it would take very long, more than 10 or 20 years to bring this technology to patients, because this is a newly generated stem cells by scientists. But to my surprise, one physician scientist who is also attending this symposium online, Masal Takahashi, she brought iPS cells to patients in only 7 years, much faster than I anticipated in 2007. So she generated, Dr. Masal Takahashi generated iPS cells from a patient suffering from age-related macular degeneration. Then she differentiated patient own iPS cells into retinal cells, shown here by microscope, and also shown here without microscope. And they cut a small piece of this retinal sheet and transplanted it back into the patient. We helped Dr. Masal Takahashi a little bit, and we were able to publish the outcome in New England Journal of Medicine in 2017. So we found no sign of rejection, no sign of tumor formations, and the vision of patient has been stabilized. So I have to say this very first clinical trial, first in man application of iPS cells was successful. However, at the same time, we learned hurdles from this first application as well. This is one of the hurdles regarding autologous iPS cells. We need to go through all of these processes. And we found it is too expensive and too much time consuming. It took nearly $1 million US for just one patient, and it took nearly more than 6 months to go through all of these processes. So at the time being, it is too expensive and too time consuming to apply this autologous iPS cells to thousands of patients. To overcome these practical issues, we have been working on iPS cell stock for regenerative medicine. So we make iPS cells not from patients, but from instead from healthy volunteers. In this case, we need to worry about immune rejection, and the best way to minimize immune rejection is to match HLA haplotypes. But HLA haplotypes is very diverse. So it's next to impossible to match HLA in each patient. So in this slide, I show the HLA haplotypes of 10 individuals in the upper portion with different colors. So none of these 10 individuals have the same color combination. So they all have different HLA haplotypes. However, if we identify this kind of HLA homozygous donor, in this case, who happen to receive the same HLA haplotype, in this case, red, from his or her mother and father, the situation is very different. By making just one good iPS cell line from this one HLA homozygous donor, we can cover 4 out of 10 individuals shown by the arrows, because these 4 individuals have red and something else. So as long as he or she received red from HLA homozygous iPS cells, it's matched. However, of course, our immune system is much more sophisticated. For example, in this individual who has red and green, when he or she receives, if he or she receives just red, he or she should think, well, red is okay, but we miss green. So we cannot avoid such kind of missing self reaction by NK cells, but nevertheless, by matching HLA, we believe that we can significantly lower immune rejection, and we can significantly lower the amount of immunosuppressant. And it's been shown in clinical trials by Masal Takahashi that this approach is feasible. So this is what we have been doing for the last 10 years. We have getting a huge help from Japanese Red Cross Society. They have a huge database of HLA haplotypes in the Japanese population. By getting a huge support from them, we have been able to identify more than 50 HLA homozygous donors. And once we get informed consent from those donors, we collect blood samples. In the case of cord blood banks, once we obtain informed consent from the mother and also from the child, we receive cord blood samples from the banks. And we have been making, generating clinical grade iPS cells in our cell processing facility. After performing rigorous quality check, we make stocks, frozen stocks of these HLA homozygous iPS cells. And we have started distribution of these clinical grade iPS cells in 2015. So when we started this project, we thought making clinical grade iPS cells would be 10 times more difficult than making research grade iPS cells. But in reality, we learned making clinical grade iPS cells is at least 100 times more difficult than making research grade iPS cells. To make research grade iPS cells, all we need is just one hardworking graduate student or a postdoctoral fellow. However, in order to make one clinical grade iPS cell line, we took this numbers of people, nearly 100 people. So it's been very, very challenging, but so far we have generated iPS cells from 7 HLA homozygous donors who have the top 4 most frequent HLA haplotypes among the Japanese population. These 7 donors alone could cover up to 40% of all the Japanese population. That means nearly 50 million Japanese people can be matched with these 7 lines. These lines have been used in clinical trials, in multiple clinical trials. So these are the list of clinical trials in Japan. Shown in pink are already ongoing, including Parkinson's disease, macular degeneration by Dr. Masal Takahashi, retinitis pigmentosa, also by Dr. Takahashi, corneal epithelial stem cell deficiency, head and neck carcinoma, cardiac myopathy, some blood disorders, thrombocytopenia, spinal cord injury, ovarian clear cell carcinoma, and cartilage defect. Except for this head and neck carcinoma, all of these clinical trials, they use our HLA homozygous iPS cell line. And also some others very close to clinics in the very, very near future. So I don't have time to go through all of these. Just let me focus on just 3 of these clinical trials. The first one is a clinical trial for corneal epithelial stem cell deficiency, which is by Dr. Koji Nishida in Osaka University. So from our iPSO stock, they can make corneal epithelial progenitor cells. Then they can make this kind of corneal epithelial sheet shown in this picture. And then they transplanted this newly formed corneal seed back into 4 patients so far. And 3 out of 4 patients actually showed immediate and significant recovery of their vision right after the surgery. The remaining 1 patient has been kind of unstable in terms of vision. So at the moment, we cannot judge the 4th patient, but at least 3 out of 4 patients showed very promising result by transplanting iPS cell-derived corneal sheet. This is the second application I want to introduce, which is immune therapy for cancers using iPS cells. So this is by Dr. Shin Kaneko, our colleague at Tyra. Once again, from our iPS cell stock, they can make NK cells, but this is not just normal NK cells. They transplant chimeric antigen receptor CAR, recognizing GP3 antigen. GP3 is a tumor-specific antigen. They are not expressed in normal somatic tissues. They only expressed in some cancer cells, including ovarian clear cell carcinomas, and also some fetal tissues. So they generated iPS cell-derived NK cells expressing GPC3 CAR chimeric antigens. Then they applied these NK cells IP. And these patients are suffering from peritoneal metastasis of ovarian cancers. So they have no other treatments. But by doing this new approach, it's still very early, but Dr. Kaneko and his colleague are seeing some promising results so far. So this is another example of iPS cell-derived cell therapy ongoing. The third one I want to share with you is by Dr. Koji Eto, who can now generate functional platelets once again from our iPS cell stock. So they are now trying to use these iPS cell-derived platelets in transfusion. Japan and many other countries are growing society. We are having more and more elderly people who would require platelet transfusion, but at the same time, we are having fewer and fewer younger generation who can donate their own blood. So in 5 years or so, I'm sure we will short on blood donors. So this kind of alternative approach will be extremely important. So once again, we have been, Tyra has been providing this autologous Ethereal homozygous iPS cell lines. Once again, so far we can cover up to 40% of the entire Japanese population. But of course, we want to cover the remaining 60%, and also we want to cover the entire world population. Through this Ethereal homozygous approach, it would be next to impossible because we would need nearly 1,000 Ethereal homozygous donors. But thanks to CRISPR technology, which was introduced in 10 years ago or 2012, we can now edit HLA genes and related gene by CRISPR-Cas technology. So that's what we have been working on in the last few years. We are now generating genome-edited iPS cells from these HLA homozygous iPS cell lines. And we expect, at least in theory, as few as 10 lines would be sufficient to cover most of the world population. So this is our strategy. We are knocking out HLA-A, HLA-B, but we leave HLA-C to suppress missing self immune rejection by NK cells. And also we are deleting C2TA transcoactivator to suppress all of class 2 MHC. So HLA-C is less diverse. By preparing like 10 HLA-C haplotypes, we should be able to cover the entire world population. So far, we have provided HLA homozygous stocks to more than 30 institutes. For academia, it's free of charge. For industry, only $1,000 per line. These are nearly, most of them are in Japan, but we are now shipping these cell lines abroad as well. We have been discussing with FDA, and we are now confident that our iPS lines can be used in the States and hopefully in other countries, in European countries as well. We have been getting requests from 29 institutes abroad. As for genome editing lines, we have generated research grade lines already. We have provided those research grade lines into 19 institutes, and clinical grade line are in progress. So in addition to these two approaches, HLA homozygous approach and genome editing approach, we are also working on autologous transplantation, which we name My iPSO project. So once again, at the moment, it's too expensive and too much time consuming. We need 3 skilled employees to generate one iPSO line, to generate iPSO lines from one donor. And these 3 skilled employees can make only 3 donors, iPS cells, and each donor could cost up to $400,000. It's very expensive, but by applying automation and this kind of a very small closed system, we are hoping by 2025, we will become able to generate one iPSO lines from 1,000 donors each year, and each line will cost only $10,000. So this is our goal in the next 3 years. So we are going to have 3 different approaches in terms of iPS cells. At the moment, we don't know which one will be the best. Probably it depends on each patient. It depends on each application. So preparing all the 3 applications is, I think, is very important. So I would like to thank all of my colleagues at CIDA and many other scientists who we have been working together, including Dr. Masal Takahashi. And with this slide, I'd like to finish my talk, and I would be happy to take any questions or comments. Thank you so much again for your attention. Thank you very much.